Well, thank you for having me. I know some of you, but not all of you. I've just noticed that two of my fellows are over there on the side. We have a new Center for Patient Safety Research and Innovation. It's downstairs on the 9th floor. And we have 3 new fellows coming in next year, and we're always looking to collaborate. So when you see the presentation and see some of the things we're doing, just keep that in mind. I'm a physician, internal medicine. Do I have like a pointer thingy? I mean, something to advance the...
I can get you that, just you can keep going.
Okay, so I'm a physician, internal medicine. I practice as a hospitalist. I also have an administrative role. I'm the Chief Patient Safety Officer, Associate Chief Quality Officer for Columbia, and I'm a researcher. And today I'm going to talk about research, but I'm going to connect it to my operations job as the Patient Safety Officer for Columbia. All right. Perfect. So I'm going to talk about wrong patient orders. I'm talking about physicians, PAs, nurse practitioners placing orders on the wrong patient and give you some examples. And then I'm going to talk about it in the context of what's called a just culture. This is where I'm going to jump into my safety role and talk about how in the real world we look at these kind of errors. And then I'm going to talk about some of my research and how we're going to try to prevent these errors. So this is our true story. Mrs. X, I'm sorry I read a couple times through this presentation. Mrs. X is an 87-year-old female with a history of hypertension, COPD, and coronary disease. She's admitted to a tele unit with a diagnosis of rapid atrial fibrillation, an arrhythmia, fast heart rate, and bronchitis. The day after admission, a medicine resident, a first-year medicine resident, accidentally placed an order for methadone. For those who don't know what methadone is, it's the drug that you give heroin addicts to help them try to come off heparin. It has a longer half-life. So a medicine resident accidentally placed it for Mrs. X when he meant to order it for a young heroin addict. Both patients were on his hot list in the electronic health record. Pharmacist signed off on the methadone order. And then a nurse in training who was working under the supervision of a more experienced nurse administered the medication. So this error was a real Swiss cheese model of error. Experienced nurses know we don't give methadone to little old ladies. We don't have a lot of little old lady heroin addicts. But this was a nurse in training who wasn't as closely supervised as they should be. Several hours later, Mrs. X was observed to be restless and complaining of being hot and nauseated. Shortly thereafter, she was found unresponsive, pulseless, and with blue extremities. A code was called, she was intubated and transferred to the ICU. So this is an example of placing an order on the wrong patient, a real example where it caused harm, and I can give you many others. This is from the Gazette of Health from London from 1820. So we are November, so we're about 2 months away from, as far as I can tell, the 200th anniversary of the oldest wrong patient order I can find. It said, having another patient of the same name in the hospital whose complaint was violent spasms and flatulence of the stomach, the prussic acid was by mistake administered to the wrong patient, a circumstance highly credible to the apothecary and by no means uncommon in London hospitals. It's 200 years later, and I think these errors are by no means uncommon in New York hospitals. This is a medication safety alert from ISMP. They're the leaders in medication safety, and they reported a case. Oops, sorry, wrong patient. I kind of stole that from them in my title. This was a story of a patient in the ER who was having some respiratory issues. There was another patient in the ER who needed some sedation, and the physician accidentally gave the sedative to the patient who was having respiratory issues, and that patient died. Just another example, and I can give you more. I was interested to know, how often does this problem happen? How often are we placing orders on the wrong patient? And it's very hard to find anybody who did any sort of quantitative analysis. And I found this one report from MedMarks. This is a voluntary reporting database. And they had said that there was a mean of, in hospitals that use electronic health records, a mean of 9 wrong patient errors per year reported at 120 facilities. So just to give you an idea of how often these are reported to happen, most of these 9 were near misses. They didn't actually cause harm. Now, there are some health IT experts here that you may know. Joan Ash is pretty famous. And she and other researchers had done some qualitative focus groups to try to understand, why do we have this problem? Why do people place orders on the wrong patient in an electronic health record? And she coined this term Juxtaposition error. When two names are next to each other, you mean to click on one and you accidentally slip and click on the other. After her focus groups and qualitative review, that's what she thought was the main cause of wrong patient orders. So now I'm going to switch a little bit to just talk about this in the culture of real world and how, as a patient safety officer and a hospital leader, how do we approach these kind of errors? So in this particular case, of the little old lady who got methadone, it went through a peer review. Other medicine doctors sat around the room and discussed this terrible error, and this is what they said. An H1 attribution, H1 meaning bad doctor. An H1 attribution was assigned to the intern for failure to correctly identify that he was placing an order for the wrong patient. Prudent medical practice dictates that care is taken to verify and ensure that orders are entered for the patient that was intended. Failure to do so can lead to negative consequences as occurred for this patient. The intern will be counseled. So, of course, you got to know who you're placing orders on. This intern didn't know, they didn't look carefully, and so he was being counseled. That's what the medicine committee felt. Now, many of you may have heard of this report, To Err Is Human. It came out in 1999. It said that 98,000 people die a year from medical errors, and it sort of launched the modern patient safety movement. The report had more than that one number, of course. In it, it said the common initial reaction when error occurs is to find and blame someone. However, even apparently single events or errors are due most often to the convergence of multiple contributing factors. Blaming an individual does not change these factors, and the same error is likely to recur. So here I just showed you a real-world example of a terrible error and sort of the feeling of the medicine leadership. But then this report is sort of saying this is not the right approach. The report went on to say preventing errors and improving safety for patients requires a systems approach in order to modify the conditions that contribute to errors. People working in healthcare are among the most educated and dedicated workforce in any industry. The problem is not bad people. The problem is that systems need to be made safer. So I really believe in this, and a lot of my research is about making systems safer. And a lot of my professional work is to try to change the focus in the hospital, to stop punishing people, and try to think about the systems. The man who did the research to show that 98,000 people die a year is Dr. Lucian Lee from Harvard. After the report came out, he had the opportunity to testify in front of Congress. He could have focused on anything as this main issue in patient safety, and what he chose to say was the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. He went on to talk about the perfection myth. If people try hard enough, they will not make any errors. And the punishment myth. If we punish people when they make errors, they will make fewer of them. So our goal in healthcare, patient safety, is to be a high reliable system. I personally believe, and I'll make the case in a minute, that a lot of the future becoming a high reliable system lies in the people in this room, in technology. And there are other high reliable systems. Airline industry, nuclear power plants. You can't just like bump into a wall, into a red button in a nuclear power plant, like lean on the red button, and the whole place melt down. It takes a tsunami in Japan to take down a nuclear power plant, but it's very reliable. This is a famous chart. I forgot who put this together, sort of helping to define what high reliability is. Looking at the number of encounters compared to the number of deaths. So like in the airline industry, which is over here, people fly all over the world all the time. There are very few deaths compared to the number of flights. It is more dangerous at this point to take an Uber to the airport than it is to fly in the plane. When you fly in the plane, you can't help but think, I'm in a little tin can 10,000 feet in the air, and be scared. And you may not be scared of the Uber, but statistically, the Uber is less safe than the flight. Healthcare is up here. Too many people are dying for all the interactions. People come to the hospital all the time. This is Columbia. We have remarkable surgeons and doctors doing remarkable things, and then just before they're ready to go home, on not that rare occasion, somebody falls, hits their head, has a subdural bleed, and now their problems are 10 times worse than they came in because they're in a strange environment and we didn't do a good enough job to keep them from falling, or they got a hospital-acquired infection, or a million other issues. What we need to do is build reliable systems. This is something from the military called defense in depth, where the general idea is a lot of math people around the room, where imagine, we'll do a little math here. So imagine each one of these dies are like a protection that I put in to try to help prevent errors. And so if a checklist has a 1 in 6 chance of preventing an error, and a timeout has a 1 in 6 chance, and decision support has a 1 in 6 chance, all trying to prevent the same error, then the chance that the error will reach the patient is 1 in 216. But if these, instead of 1 in 6, if a checklist really had a 1 in 100 and a timeout 1 in 100, then it's 1 in a million and 1 in a billion. Meaning, like, if we have redundancies and these protections are strong and effective, then we can really start to develop a high reliable system. There's this component of human factors. So I imagine many of you look at user interfaces and the way humans interact with machines. You may know of this example. Back in World War II, almost as many planes were going down in America with all the pilot flights as were being shot down in Europe. And it was because of all these design flaws. So here is the lever for the gear and the lever for the flaps. When planes were coming down to land and it was time to put down the wheels, because the levers looked the same and were right next to each other, people would not infrequently lower the flaps. Instead, and the plane would be 200 yards and then nosedive right into the ground. And that was just a design flaw. If they looked different and were far apart, then that would decrease the chances of those errors happening. So those are some of the opportunities to build the defenses in that defense in depth model. Nowadays, I put my iPhone in my bag, but Apple can make hundreds of millions of iPhones very reliably. If you look at the plants and the work that's being done to make them, it is, I don't know exactly, 90% robotics, 10% human. In the hospital across the street, the care that we're delivering is 99% human, 1% robotics and technology. When I said I believe that you guys can help us make a high reliable system, it's probably not going to be in 10 years or in 20 years. I believe that the promise of high reliability in healthcare is in technology. At this point, compared to those old World War II planes, the pilot and the co-pilot can both fall asleep and the plane will just drive itself. I remember when I first gave this talk, I made this like several years ago, 5, 6 years ago, I was thinking like, in 20, 30 years, cars will be able to drive themselves. You can't believe how fast we got to cars driving themselves. I'm telling you, I used to talk about it, and there wasn't mention of Google and Uber, at least that I saw, of developing these automated driving, and suddenly it's like here. This is Garrett Kasparov. I'm a chess player. This is 1992, the first time a chess computer beat a chess master. 1992. Last year, Google's artificial intelligence, many of you may have heard this, made a machine that all they did was teach it the rules of chess. This is how pawn moves, this is how to castle, and it played itself for 24 hours. And then the Google artificial intelligence machine beat the best chess computer that we had at the time just by teaching itself how to play chess. This is Steve Nash, basketball player, very, very high percentage free throw maker, whatever. There's a robotic, right? And so the point is, technology can help hand-eye coordination, surgeons. It can help us think. It can help us, is this patient going to be readmitted? What are all the different factors? It can automate all sorts of processes. And while we're all working on it, this is where I believe high reliability will come. I'm going to skip this part. So one thing I wanted to say is that sometimes, like the story of the person who gave methadone to a little old lady, when we focus on punishing people, first of all, it's totally unfair to the resident. Like, it's really the system that failed them. Second of all, it's unfair to all our future patients. The easiest thing to do is slap somebody on the wrist. We feel better about ourselves in leadership, took care of that problem, we're not going to let that guy practice anymore. But really, it's the system that's the problem. We didn't actually fix the system. So we were unfair to our staff, and we're not really helping our patients, and we're suppressing reporting. This is a story of Kimberly Hyatt. She was a pediatric critical care nurse who made a math error. And everybody makes math errors, doctors, nurses, pharmacists. She accidentally gave 10 times the dose of calcium. And she was a good nurse with no issues. She knew the family really well of this child that she made the math error because he was very sick and he was in and out of the hospital. And so her error, giving 10 times the dose of calcium, led to the child dying. She was suspended for that error, then she was fired for that error, and then she killed herself. And really, we're living in a time where we should have smart pumps, the computer should be doing the math. Like, we don't have to be doing math anymore. We really shouldn't be. We should have prevented that error, and she should have been consoled and support it and saying, sorry, we should have been further along with our advancement of using smart pumps and stuff. You must feel terrible. Let me support you. Instead, they suspended and fired her. All right, so let's talk about system improvements to actually try to prevent errors. So we developed this automated measure for identifying when people actually make errors. A lot of what Gerard and Pooja, patient safety research fellows who are both physicians, are working on are developing more of these. But the first measure that we made was to identify wrong patient errors. It looks for when I, as a physician, let's say Mr. Smith is sitting here and I order on Mr. Smith a x-ray of his left knee, ciprofloxacin, an antibiotic, and a urinary catheter. And then I cancel those three things, and then I order the exact same things on Mr. Jones. The original program used to call it the oops query, like, oops, I'm on the wrong patient. Let me just catch that and fix that. So we look for when that happens within 10 minutes, like self-caught errors that are caught and corrected. Turns out it happens a lot. I'll tell you how often in a second, but it happens so often that we can call people in real time and say, hey, when you ordered those very specific things on a patient, cancel it and order it on somebody else, was that a wrong patient error? We called 236 people, and 76.2% said, in fact, it was a wrong patient error. So in one big academic medical center, in 1 year, there were 6,885 of these retract and reorder events. That if you correct for the 76%, it's over 5,000, 14 a day. 1 out of every 6 providers, at least in that year, had made that error. 1 out of every 37 patients admitted to the hospital has, for a short amount of time, has some orders for them that was really intended for somebody else, and it's caught and fixed. So do you remember me saying that Joan Ash had thought juxtaposition errors was the reason why people make wrong patient errors? Well, we got to call people and say, hey, was that a wrong patient error? If they said yes, we then had the opportunity to interview them and ask them more questions. And it turns out only 10% said juxtaposition. 80% said that the main issue was, anybody want to guess?
Interruption.
The main issue was interruptions. We heard the same thing over and over and over again. I'm admitting Mr. Smith, he's coming in, new problem, I got all the papers, I got to order his diet, I have all this stuff to do on him, and somebody calls and says, Mr. Jones has pain, can I order Percocet? So I quickly switch to Mr. Jones and I order the Percocet, and then I get interrupted. And we have a 5-minute conversation, and then I go finish Mr. Smith's admission, but actually I'm on Mr. Jones, the Percocet guy, and I forget that. You know, in my working memory, I forgot that I toggled. And now I place all the admission orders on the wrong. That was 80% of the errors. And I give a lot of talks, and I get invited to expert meetings about wrong patient errors. And everybody wants to talk about the font size is too small and, you know, juxtaposition errors. And I'm thinking it almost has nothing to do with the EHR. It's just people, I mean, I think the EHR can help prevent these errors. But it's really they're toggling between patients, and then they're forgetting who they are. It's their working memory is failing. Interruptions. I think I accidentally deleted a slide, but I wanted to remind you that we found 5,000 wrong patient errors. And if you remember that old slide that said that the most I could find before my research was 9 in 1 year, and now we have 5,000. They're all near-miss errors, but there are so many of them that they allow us to power studies. And they're very reliable. So how do you do patient safety research? A lot of people do it based on voluntary reported errors, like those 9, but that's not really reliable because, first of all, you don't have enough to power anything. Second of all, it's really subject to reporting bias. I don't think I have the slide here, but there was one study that showed photos can prevent wrong patient errors. It was a before-after study in one hospital, and they had 12 errors reported in 1 year. They implemented photos, and then it went down to 3, 75% reduction. Now, was it really a 75% reduction, or were people afraid to report errors after now there's photos and, holy crap, I saw the photo and I still played, maybe I'm not going to report it. And they knew there's a big campaign and so it's really subject to reporting errors. And the fact of the matter is we know that there are thousands of wrong patient errors. A lot of people aren't even reporting them. So this has, the Retract-and-Reorder has the benefit of they are actual errors. I mean, for a short period of time, these orders live on the wrong patient. They are real. We don't need the provider to report them. We don't need to do chart review. And that allowed for a lot of our research. The measure is the first, that particular wrong patient Retract-and-Reorder measure is the first health IT safety measure endorsed by NQF. NQF is the National Quality Forum, like all the big health safety measures that you see in U.S. News and World Report and Hospital Compare. They get reviewed by NQF to make sure they're reliable before they're used. And so that's our first measure that was endorsed. Oh, here's that slide. Went from 9 to 5,000. So we're currently doing a study to study if photos can prevent wrong patient error. So there is that one study that showed it went from 12 to 9, but we think we can do a better design. So we're actually doing it at 3 institutions, Hopkins here and Montefiore in the Bronx. And we're studying first, can photos prevent wrong patient errors with a rigorous design with a randomized trial? So here right now currently, we take photos on as many people as we can, and we randomize providers to whether they can see it or not. There's this pop-up that was made by David Vaudry and Hojat Samsayan. You guys may know them, and some others. And either you see the photo or you don't. Then we're doing a study. We're about to do a study at Brooklyn Methodist in Cerner to see if photos will prevent errors there. In Cerner, the photos, there is no pop-up. The photos are displayed as a tiny little thumb tab in the top right corner. And then we're going to be doing the multi-center study in Hopkins, Montefiore, and us will be in EPIC. And there we're doing a 4-arm study. EPIC shows the photos in a pop-up and also a bigger one in the banner. And we're randomizing 25% will see the photo in the pop-up and the banner, 25% just the banner, 25% just the pop-up, and 25% won't see it at all. And in this way, we'll be able to see, is the pop-up better than the banner, or the banner better than the pop-up? Are they additive? Should we be doing both? And then we have Lena from this department is doing like some human factors review and user interface look at the 3 different EHRs, Allscripts, Cerner, and EPIC to help try to connect whatever quantitative results we find to her qualitative review of the systems. Rigorous by doing randomized trial, generalizable by doing it in 3 of the leading EHRs, and then also we're going to make toolkits to teach other hospitals how to implement photos, all the different workflow issues that come up. Another study that we've done is, this is from a live EHR. In most hospitals in the country, when babies are born, the name that's given to them temporarily is baby boy or baby girl. I had a baby in this hospital 7 months ago. In the old days, he would have been baby boy Adelman. And we did a national survey. We got 40% of the NICUs responded, and 81% used either baby boy, baby girl, or BBBG, or something like that. And the problem is that you could see the first names all are identical: baby boy Jones, baby boy Johnson, baby boy Jackson. And so we were able to show, I think it's the next slide, that the error rate is 60% higher in the NICU compared to general pediatrics, where the kids actually have their names. And in fact, among multiples, it's like 80% higher. This is the national survey that we did that showed that it's 82%, use something like baby boy, baby girl, master and miss, things like that. But then we were able to show, if I wanted to give the kids names, I wanted to call them Cutie Pie and Buggy Bear, and I asked the head of neonatology, and she said, that's a great idea. You absolutely cannot do that. You can't start naming children like for the parents. And we said, okay, fine. So we said, well, what if we use the mother's first name? Wendy's boy, Judy's boy, Cynthia's boy. And so we agreed to that. And so that's what we did. And then this reduced wrong patient errors by 36%. We published this in Pediatrics. And then this, as of January 1st of 2019, this became a national regulation that hospitals must get rid of this baby boy, baby girl and use something like the mother's name, more distinctive. It's a Joint Commission requirement. The problem is that we, A, partially solved the problem, and B, we accidentally caused a new problem. So we partially solved the problem because imagine twins Judy's Boy 1 and Judy's Boy 2 Johnson. The names are almost identical between the twins. And most hospitals' medical record numbers are given out sequentially. So these two babies are born one right after the other. The medical record numbers are the same except for one digit. The names are the same except for one digit. And so it turns out that, as we suspected, the error rate between multiples is higher than singleton. So the chance of a singleton having an error is 1 in 26. The chance of twins, 1 in 13. And the chance of multiples, 1 in 7. In fact, if you look at it from the parent's perspective, if I'm a parent of a set of twins, 1 in every 7 set of twins has a wrong patient error, and 1 in every 3 sets of triplets. So if you have a set of triplets in the hospital, it's a 33% chance you can have a wrong patient error. And it's because the names are almost identical. So we're doing a study now from the NIH that's very similar to the photo study, except we didn't really think that pictures of these kids was really going to help tell them apart. So instead, we came up with this idea of pictographs, where we already had an illustrator make 400 cute little pictures of different things, and then if you know Hojat, who's now at the Brigham, is making an app within Epic where a nurse can go to a parent and ask them to pick their favorite little image, and then it'll check it out. So once they pick it, it'll be uploaded into Epic in the EHR. A sign will be printed that will go over the bassinet. Little labels will be printed on the breast milk, and it'll be checked out so we don't have like 7 lions in the NICU at the same time. And then once the kid leaves, then we can use it again. This is this is the app that Hojat's building. And then we'll put it on the. We have a lot of breast milk errors where it's very upsetting to the families when you find out that we accidentally gave another mother's express breast milk to your baby. That's very upsetting. And one case that happened, we now have barcoding to help try to prevent it. And the nurse brought over 2 bottles, and the mom wanted to feed her baby, and just what the nurse was looking, grabbed one of the bottles and grabbed the wrong one. But now, if the mom knows her son is a lion and sees a rocket ship, then maybe it'll just simple visual cue. Yeah.
Do you have a process around putting up a picture next to the baby? I'm assuming that if one twin is a lion and another twin is a rocket, a prime point for error is putting up those images in the first place.
We haven't started the actual project yet, so it's a very good point, and it's something that we've been talking about, is how to be very careful about that and putting the labels on the breast milk correctly and so forth. So we don't have that process worked out, but we've identified that that's a very important process. Okay, another issue. How many tabs should you allow open in electronic health records? So we're about to go to Epic, and Epic allows 4 records open. There's a big national debate. Everybody wants to know on all the CMIO blogs and how many records to allow open. This is my first grant. To help try to get the grant, I did a national survey through listservs, and I asked CIOs and CMIOs, what system do you have? Does it allow multiple tabs open? How many do you choose to allow open, and why? And it turns out that about 40% chose to allow the maximum open, unrestricted, and they believe doctors and other staff need to multitask, and it's allowing them to open one record, and they're working on something, and then something else comes up. You can open up another record at the same time and then go back. They think from a process perspective that was better. But almost the exact same number restricted to 1. Often those people had experienced a wrong patient error, attributed to having multiple records open, and decided the risk of the benefits from having multiple records opens are outweighed by the risk of wrong patient errors. At the same time, we worried about wrong patient errors, so we split the baby and hedged it too. So without any evidence at all, ONC that did meaningful use, based on their general belief of some national experts, they said we should really limit to 1. That was the official safety recommendation from the SAFER guides from ONC. And then the Joint Commission that regulates most hospitals copied that. So we were in a situation where the world was evenly divided. The regulatory bodies were saying you should really restrict to 1, but there really was no evidence. So what we did was, at Montefiore, when they went live with Epic, we randomized all their providers, their physicians, their residents, their PAs, their MPs, anybody that placed an order. we randomized them to either being able to have multiple records open, which the maximum in Epic is 4 that you can place orders on, or being restricted to 1. And then we used the Retract-and-Reorder measure as the outcome measure for the study. And here's what we found. The error rate between the two groups overall was 90 versus 88. The odds ratio was 1.03. The P was 0.6. And that was pretty much true in every environment. The place where people were most concerned about multiple records open, where it's most used and most concerned, was the ED. And the odds ratio was literally 1.00. And so you can see there's really no difference between 1 and 4. And that retract and reorder measure made it possible to do this study. While we had people randomized to these two different groups, we asked them, every other condition was the same. They were working in the same hospital. The EHR was exactly the same alerts. The only difference between the two groups was they were either restricted to 1 or could open 4. We gave them the same survey and asked them about their satisfaction. And those that could open multiple records had a much higher satisfaction, as you can see. And it was true in all settings: inpatient, outpatient, emergency room. So now we have another grant from HRQ to try to make more measures. This general, and this is a lot of what Gerard and Pooja are doing. Our general hypothesis is that if you place an order, and shortly after you place that order, you cancel the order, there's a very good chance you made an error. Why would I, if one of you were my patients, why would I order a drug on you and then 20 minutes later cancel that drug? Unless you were like going home or going to the operating room. I could see like a day later, maybe you had a reaction, maybe you got better, maybe something changed. But 5 minutes later, 10 minutes later, why would you place the order and then change it before we even had time to give it? Why would you order an x-ray before you had time? Maybe I ordered the wrong test. And so if we looked at all the orders that were canceled and then reordered on the same patient but changed some aspect of it, so specifically for medications, what if I ordered clonidine on one of you, canceled it, and then immediately ordered Klonopin on one of you? Maybe that was like a sound-alike clonidine, Klonopin error. Or what if I ordered one dose on you, canceled it, and then changed the dose? Maybe that was a dosing error. A lot of dosing errors in pediatrics where babies can, weigh anywhere from 1,000 grams to 500 pounds. Like the dosing varies a lot in pediatrics. We set up a machine. It's not really a machine, but I call it a machine, where we have all of our different hospitals send data to Jupyter, and every 30 minutes we look for a retract and reorder event, like somebody ordering and changing dosing. And then if there's an event, our programmers figured out how to do this with Hojat's help. It takes a Qualtrics survey, puts all the information about the patient and the order in the survey, and then has all these spaces for our research coordinators to call a resident and say, hey, I noticed you ordered 10 milligrams of morphine, cancel it, and then ordered 1 milligram of morphine. I saw you did that on Mr. Smith, and you did that 22 minutes ago. Could you mind, I have IRB approval, trying to make the hospital safer. Can I ask you some questions? Was that a wrong dose error, and if so, why? And there's more subtlety to the questioning than that, but we're trying to really understand, we're trying to develop a valid measure for other kinds of errors so we can do the kind of research that we did, we can describe it, and we're also trying to understand the mechanism of errors. I don't know of too many things, in fact, I don't know of anything else where somebody made an error and you can interview them within a few minutes of making that error. I often think of, like, imagine a surgeon who accidentally nicks on an artery, and you hear this booming voice, excuse me, Dr. Adelman, I saw you just nick that artery there. Can you just say, what happened? Were you distracted? But we literally can do that. It's like, to me, it's very cool that we can do that. So here's actual NYP data from 2018. Across all of NYP, 364,000 times somebody placed an order and canceled it within 30 minutes. It's like a massive amount of times. What's going to happen to this number when NYPs goes from all scripts to Epic? Is it going to go up? Is it going to go down? The user interface is different. The decision support is going to change. Maybe when we go to Epic, it's going to really go up, and then as we get better at it, it's going to come down and people get used to it. We don't know. And then 93,000 times somebody places an order, cancels it, and then reorders the exact same thing back on the same patient. Skipping this. Just going back to connecting back to I think I made this point already, but that wrong patient error case and connecting like the research that we're doing to my real world job, every time somebody makes an error, dosing error, wrong patient error, and then we wind up punishing them for not knowing any better, in my view, we're really being unfair to our staff. We're not really working on fixing the system, and we're suppressing error reporting. And so I'm trying to move the culture of our organization to understand and appreciate more of the importance of system thinking and informatics in health IT safety, and stop blaming providers for being humans, but focus on making our system safer. This is Don Berwick. He's sort of like the founder of IHI and the modern safety movement. He and Paul Battleton once said, "Every system is perfectly designed to achieve exactly the results it gets, and the most serious errors are committed by competent, caring people doing what other competent, caring people would do." So, okay, we went over wrong patient errors. They occur frequently. Preventing wrong patient errors requires system thinking. Blaming providers for human errors is unfair and distracts from addressing the real problems. And I personally believe technology, the work that you guys are doing, is the key to achieving high reliability in healthcare. So with that, I'm very happy to take any questions. Thank you. Yeah.
I'm curious, and this is not a technical question, it's an IRB question. I'm curious because the most common cause of the errors is interruption. Did you have any issue IRB-wise having a protocol in which you interrupted the clinician to ask them?
Good question. Well, I mean, I guess
it's another interruption.
That's fair enough. Well, first of all, the answer is no. But your point is well taken. And we're learning a ton about interruptions by interrupting. I don't know what to say about that. I don't think like stopping phone calls is going to be the solution to interruptions, but identifying what that interruptions are a problem may lead to real, like maybe the people placing orders should not have a phone that none of us can call them, us, the pharmacists, nurses, family members. I don't know exactly, but yeah.
Another regulatory question. So for studies like when you do the 4-group banner versus other picture, who do you do informed consent on, if anyone, and like how do you get around that issue? Versus possible consent of the patient in the hospital?
Yeah, we met the criteria for exemption for consent. So for all the studies that I've showed you, the photos, the pictographs, and that trial, they've all been exempt from consent, thankfully. Yeah.
I have 2 questions. One is just like trivia. Do you see a difference between July and June?
Didn't look at it. Can we look at that? July and June? I don't know. That's a good question. There's a lot. I think there's a lot. We have this massive database of errors, and there's a lot of questions that we have not yet asked of that database, and that's just wrong patient errors. Right now, Gerard and Pooja are finalizing the wrong dosing error, wrong frequency error, and so soon we'll have even larger database of multiple types of errors, and we can ask those kind of questions.
I look at day and night too.
And day and night. Weekends. PAs versus house staff, and sorry.
More like an abstract question, I guess. Always thinking about the checklist manifesto.
Yeah.
How it was so meaningful that I couldn't think about. But I think of it as like perfect case is a surgical case where it's sort of a staged linear process. When you move out of the OR and you go to the floor for general medicine, things are not linear with overlapping processes. And so to make something highly reliable, is it that you need to find the sort of micro transactions that are still always linear, like entering an order, or is it that you change the workflow that is current into a more structured linear process?
It's a great question, and I think anybody that pretended to know the answer to that question would just be, pretending that their hypothesis was fact, but really nobody really knows. I think our contribution to that question, in my view, is only one part of the error world, but I think it's in these measures, meaning that, like, I think we should set a goal to get these 364,000 down to 0. If we get to a point where people, when they place the orders, they are the right, best order, then I think we'll really be much closer to high reliability. And that might come from, like, some of the problems are interruptions. Some of it is knowledge deficits. I mean, what we can do now is call people and really try to understand that in real time, and I don't know anyone else that can do that. And then we have a measure to assess effectiveness in studies. And so I personally believe, like, I'll give an example. One of the things that Gerard and Pooja are working on is that there are, I don't think I put a slide here, but I think it's about 20,000 times somebody changes the dose a year. Is that right? About 20,000 times. Sometimes they change the dose from 10 milligrams of morphine to 1, just a clear error. Sometimes they change an insulin dose from 21 to 20. It's like a micro change, and we call those like adjustments, right, or changes more than errors. And I personally think that work that you guys, that some of you may do using decision support and machine learning and artificial intelligence, we may get to a point where the computer says, I've analyzed all patients, your patients, everything we know about it, and the right dose is 21. Don't question me. It's the best we can do. And then even those adjustments may go away, and these numbers will go down. So some of it might be we need quiet spaces to deal with interruptions. Some of it's artificial intelligence. And there's just so much. The airline industry is a high reliable industry, and I don't mean to oversimplify. For the most part, they, take off, fly, and land, and manage our luggage. But it's sort of like your example of surgery, where it's just like one thing. We have to worry about teenagers who are suicidal, babies that weigh less than a pound, radiologists reading films, pathologists doing autopsies, and just everything in between. It's so complicated and interwoven that I just think it's going to be some time, and we don't even really understand the question, let alone the answer, or all the questions. Yeah?
I was thinking with the knowledge and perspective, so I think a lot of us try to distinguish between what we observe and electronic, and either as an error or an error, those are all different. There's another phenomenon I think they hypothesize. So, do you think, in your opinion, that a lot of things that we observe is being considered like when we're logged in, like some certain errors could be in public on the weekend, or maybe like certain times of the year or something, or any way to take the condition on that, and our methodology would not sort of take into account other things due to our error that we observe, so we can get to more interesting phenomena that being lost from the water and kind of taking out the type of capabilities from others.
Yeah. I wish I had a slide to help answer or address your question, but I'll just describe it. In this study, there was no difference between people randomized to 1 or people randomized to 4. But in the group that was in unrestricted, randomized to 4. So this is like complicated. If you're interested, just focus in for 1 minute. So it's the people that could open up to 4. We paid Epic $50,000 to build a log to keep track of when every order was placed, how many records were open at the time. 3 records, 2, whatever it was. And then we looked at the error rate only in the unrestricted group when they had 1, 2, 3, or 4 records open. And it turns out the error rate went up. And when they had 4 records open, it was much higher than 1. So now the question is, how do you reconcile this randomized trial with the fact that in this arm, the error rate went up, but there was no difference? And our thinking is that when people have multiple records open, so when they chose to have 1 record open, the error rate was much lower than when they were forced to have 1 record open. But the blended of 1, 2, 3, and 4 was exactly the same. This is sort of like the blended. All the orders when they have multiple records open, And so, are you following me? And so what's the explanation for that? And we think the explanation is, I got George's input on this, is confounding. That when people have multiple records open, it's more likely that they're multitasking. They're switching between patients. In fact, the people that are restricted to one are doing the exact same thing. It's just we're blind to it because they only have one record open. But I can tell when somebody, if they have 3 records open, obviously they're working on 3 patients. If they're restricted to one, they may be working on 3 patients, but I can't see it. And so the real issue is, the true issue is multitasking, which is what we had said, multitasking and interruptions. That's what, so the point is, my point that I'm not making well, to address your issues, I think that there are lots of contributing factors like interruptions and multitasking and nights versus day. And all I can say is that I think that our research will help elucidate those by these kind of studies, both quantitatively and qualitatively with the phone calls that we're making. We get to interview people in real time and ask them, what was going on there. And it's such close to real time that where people could say, I was thinking about my daughter who's sick at home. Like when I chair an RCA, I'm often talking to people 4 or 5 days after. But when we call people, it's often minutes after, and they can literally remember like what was on their mind, and to the extent that will help.
2 sort of related questions.
Yeah.
The first is, based on that hypothesis, do you think it's possible to study multitasking in the setting where you're restricted to one chart open at a time? And the second related question is, do you think there should be sort of an intermediate lockout where, if you're away from the terminal for long enough, you get locked out for security reasons? Do you think that if you're interrupted for long enough, you should be sort of asked, which chart do you want to be viewing now? You had 3 open, and you think that would alleviate some of the errors associated with interruption?
So as far as your first question, I try to make this is where, again, we can collaborate, and I just need the right people, but I try to make a measure of, let's say, busyness that was independent of number of records open. Like if somebody was, I tried to codify every order to say how many orders were placed on different patients before and after that order, which would sort of suggest they're multitasking. And then apply it to both arms to see if when they were busier, meaning they're placing orders on multiple patients, did the error rate go up? And it worked to some extent, but it just I need to put more effort into that. And I think there are other creative things. Like we could see if somebody is sort of working on the EHR and there's like a time pause of 2 minutes and then they continue, maybe that would be another variable, a way of trying to take confounders, unmeasured variables, and try to find measures for those confounders. So 1 would be multitasking, 2 would be those time gaps. And then your second question, yeah, I don't think we are anywhere near the end of all the creative things that we can do to try to allow people to multitask for efficiency, but still help prevent them from preventing wrong patient error. So you had suggested which tab exactly do you want to do? You have 3 tabs open. I hope that the photos even will help. That if the corner of your eye, you think you're on a young female and you see an elderly male, that's a good thing about pictures, is that the names are written on the top, but people don't process words that easily. But you could not even be looking directly at an image and understand the age, race, gender are different than what I expect, even by directly looking. Yeah.
Do you think that patient complexity is a factor? Because you're assuming that the person who has 3 things open, the patients are equally complex as the person who has either 1 record open. And anecdotally, you're like, oh, I have 1 really sick patient, and that is enough to make an error. So have you compared error rates between, just case, severity index scores, or is that something that I always learn, that if you're sick patients, you're more likely to make mistakes, or is that true?
Yeah, so I have 2 things to say to that. First is we're a relatively small research team, and again, I invite you guys to collaborate because there's so much in this data. I honestly, I don't know of data sets like this where, for over several years we have thousands of errors, hundreds of thousands of orders, and they're actual errors. They're not self-reported And so with all these covariates, but we've been very focused on sort of like solving these main problems that we haven't asked the interesting secondary questions like that just because of time and resources. And then my personal hypothesis is that it doesn't really matter. It's really multitasking and interruptions. I think the main issue, at least with wrong patient errors, often is working memory, where when I switch a lot and I'm trying to keep all these things in my head and I don't have time to jot down, wait, I'm pausing, let me just write down, I got to go back to this. I think that's the main problem. However, things that like Adler suggested are photos. There may be things in the EHR we can do to help. If you forgot what you were doing, it pulls you back to what you were doing, and you just don't have to rely on your memory. Yeah. Sorry.
I just want to ask, because you gave some methods for example, provide visual cues,
Yeah.
so that even though you're interrupted, you're less likely to make mistake. You have the retract, which is after the interruption, you can fix it.
Yeah.
But how about like prevent the interruption to happen in the first place?
So actually, I got a chance to go over this quickly with Adler, and he had a great suggestion that I never thought of, which is actually if we could create predictive modeling to predict when an RAR event would happen, and then we could use RAR events to test it. RAR events are like sort of by the grace of God, you catch yourself. But what if not every RAR event is the little old lady that got the methadone was something that should have been an RAR event, but it just wasn't caught. And so maybe if we can predict what are the circumstances, I guess it's also to your point, what are the circumstances that lead to errors, really understand them, then maybe we can prevent them before they become self-caught. Like these, retract-and-reorder events, thankfully they're near misses, but we don't want to rely on people, catching themselves. That's not a reliable system for safety. And there are thousands of these things, and when they fail, people get hurt. But there's more work to do on that for sure. Yeah. Yeah.
Yeah, I was just thinking you also need like environmental measures, because the person sitting in an environment, and it matters how busy they are, but it also matters probably how busy the unit or the setting that they're in is as well.
Yeah.
And at least when you look at, and so I think a measure that accounts for some of that environmental busyness as well. And this has been done in many years ago in things like nursing workload, and it's not just how busy the nurse is, but it's how kind of busy the unit is. And then the other thing might be kind of a measure of throughput in their setting, because I think both of those environmental contextual factors influence what the person is doing,
Yeah.
not just their own measures.
I can imagine like something as simple as like keeping track of noise on units for a really long time and then going back and look at retract-and-reorder events versus loud noise as some sort of marker for interruptions and a million other ways to do that. Not my area of expertise of but I can see your point and that could be useful.
One more?
Yeah.
So real quick, it's wonderful that you're doing the safety research, especially looking at it from perspectives that seems like it's doing much better than the ways they were measured previously. I guess my question was, do you ever get any pushback working for NYP or some other large hospital group that by using a new approach, you're more accurately measuring, but suddenly your error reporting rates are much higher than existing in literature? Like, does that look bad that you now have thousands where you previously had none?
So far I haven't. I got the measures that we're using are near miss errors, and it's not like we just sat down and said, let's come up with near miss errors. It was just, we discovered we could do this. We felt it would be useful for studying the effectiveness of interventions. And it turns out that the good thing about near miss errors are, one is we're not really reporting that we've heard all these people, we're just reporting self-caught errors. So that seemed to fly with leadership, to your point. Two is there are many more near miss errors than there are errors errors that cause harm. So it just gives us more power to do these kind of studies. It does require that you accept that the causal pathway for near-miss errors is the same as errors that cause harm, because we're actually just showing a reduction in near-miss errors. So you have to have that leap. But so far, we haven't had that issue. If all these errors cause harm, it might be a different story. I don't know. All right. Thank you, everybody, very much. You're welcome.
That's great. That's great. I think that might have been the most engaged we've had the audience this year.